It's now a pleasure for me to introduce Dr. Arthur Sasahara. Dr. Sasahara and I will be co-chairing the introduction of the speakers this afternoon. But what's really special for me is that when I was a senior resident at the then Peter Brigham Hospital, I had the privilege of being ARC's chief medical resident at the West Roxbury Veterans Administration Medical Center. And he had been working in this field, as I think he'll share with us, in the 1960s, publishing this new technique of pulmonary angiography in the New England Journal of Medicine. In the 1970s, using thrombolytic therapy with urokinase and streptokinase in the first large multi-centered trials of this disease. And Art is one of the 4 members of the board of directors of the North American Thrombosis Forum, NATF, a founding director, along with Dr. Jawed Fareed and John Finikos, and has really been someone that we turn to for guidance and inspiration and mentorship. Art, we welcome you to educate us about the history of venous thrombosis.
Thank you, Ken. That was a very gracious introduction. I wish my wife were here. Venous thromboembolism, probably a very old disease. From the records, one could see some examples of it, and what I could find was probably the first case of thrombophlebitis was in an illustrated manuscript, The Life and Miracles of Saint Louis, which is in the Bibliothèque Nationale in Paris. The second case of probably post-thrombotic syndrome, or the old post-phlebitic syndrome, was in an Italian nobleman who had persistent leg swelling following a serious medical illness. And the third case is the infamous Henry VIII with his 6 wives. Henry VIII apparently suffered multiple leg trauma and leg ulcers during his youth, and subsequently, in adult life, suffered chronic swelling of the leg. Again, a case of probable post-thrombotic syndrome. Now, on the upside, the fact that he had chronic swelling and leg ulcer apparently didn't hinder his activities in bed. The current concepts of pulmonary embolism probably begin with Laennec. Sorry, it should have been L-A-E-N-N-E-C. And Laennec was a brilliant clinician, short-lived unfortunately, and who spent most of his professional life developing the science and art of auscultation with the stethoscope. And he finally published his treatise on the diagnosis of diseases of the lungs and heart. And in that text, he described pulmonary apoplexy, stroke, a pulmonary stroke, which subsequently Rokitansky, the German pathologist, recognized and called it a hemorrhagic pulmonary infarct, which is really what it is. Rokitansky also forwarded the concept of emboli, but that's debatable at this point, and some historians attribute that to Rudolf Virchow, and I'll discuss that in a little while. Here is Laennec. There's a very nice signed portrait of Laennec in the rare books room at the Conway Library next door. If you get some time, really look at it. The third giant in Europe for venous thromboembolism was Rudolf Virchow. Westernized, I guess it's pronounced as Virchow's triad, as we know him, but it's Virchow. And he was a slight person in physique, but he was also an extremely talented clinician, pathologist, an experimentalist, and epidemiologist. And as soon as he got through medical school in Berlin, he began to study thrombophlebitis. That was the hot topic of the day, interestingly. And Virchow spent the next 10 years studying thrombophlebitis, making clinical observations, doing some clinical studies, looking at autopsy findings, and finally, after 10 years, he published his treatise on venous thromboembolism. And it's pretty simple. What he said was, in order to get a venous thrombus, there should be some alteration in the blood. We now call it hypercoagulability. There should be an alteration in the blood vessel. We now know that it's endothelial damage. And thirdly, there should be some alteration of the blood flow, and we recognize that as stasis. So if you have one or more of these, as he said, the risk for developing thrombophlebitis goes up. And there is Professor Rudolf Virchow. Now, in the United States, we're lagging behind the Europeans. And William Welch at Johns Hopkins, after spending several years in Europe, published the first paper, a long treatise on hemorrhagic infarction, thrombosis, and emboli. And subsequently, the thinking moved up north to the Massachusetts General Hospital, where Paul Dudley White presided, and along with his cardiology fellow, Sylvester McGinn, described the first report of massive pulmonary embolism. And in that paper, they described an electrocardiographic pattern, the S1Q3T3 pattern. In the old days, we used to call it the McGinn-White pattern, but in these days, it's simply the S1Q3T3 pattern of massive pulmonary embolism. And then 5 years later, also at the Mass General, Hampton and Castleman published another landmark paper. Hampton was a radiologist and Ben Castleman was a pathologist. And in that paper, Hampton described the inverted cone of a pulmonary infarct, now known by the radiologist as Hampton's hump. They also described the reversibility of pulmonary infarction, and they also made the astute observation that actually PE occurs more in medical patients than in surgical patients. It's just that clinicians used to diagnose it, and hence they felt they didn't see it didn't occur very often in medical patients. Now, in the major diagnostic developments, probably goes back to 1935 with the electrocardiographic ECG pattern, the McGinn-White pattern, the S1Q3T3 pattern, which occurs in between 15 and 25% of patients with significant pulmonary embolism. Then in 1938, venous pulmonary angiography came into being. That was a very vigorous invasive test, however, the problem was that they could only take a single picture after the contrast material was injected intravenously. And generally, it was either the picture was taken too soon or too late. And therefore, the full visualization of the pulmonary vascular tree did not take place. So, in 1964, with improved technology and all, our group took it up and decided to use a catheter to select the chamber in which we would inject a small amount of dye by a power injector using a rapid film changer capable of getting 1 film per second for 10 seconds, thereby guaranteeing the fact that one could fully opacify the pulmonary vascular tree. Also, in '64, Henry Wagner described radioisotope lung scanning. So '64 was a good year for diagnostic tests. The echocardiogram didn't come around until the '70s, and although it was used occasionally, it wasn't really a serious diagnostic tool until 1996, when McConnell, a very astute cardiology fellow here at the Brigham and Women's Hospital, made some observations in patients with massive pulmonary embolism. He noted that actually in those with big PE, that there was diffuse hypokinesis of the right ventricular free wall, but not of the apex. And it gave a funny kind of picture as he saw on the echo. And he described that, and we now know that as McConnell's sign, as Dr. Lascaldo mentioned. So if you want a sign, look for a new disease. Also in 1996, CT angiography came into being. And it was compared with pulmonary angiography and lung scanning. But it kind of ended up on the short side. The problem was it was a single detector CT scan, and it didn't pick up smaller pulmonary emboli. Until in 2001, when the multiple detector CT instruments became available, then it became a very useful test, and has subsequently displaced the use of pulmonary angiography and also radioisotope lung scanning. Now, in treatment of pulmonary embolism, heparin has been around for so long. It was discovered, in the 1924s by a medical student named McLean. It's been used subsequently. And it was only in 1960 that the first randomized controlled trial was carried out. And even then, that was only a 35-patient controlled trial before it was stopped. And there were 16 patients who received intermittent heparin, and 19 patients in the control group. But in the control group, there were 5 deaths with 5 recurrent pulmonary emboli, while in the heparin group, there were no deaths and no recurrences. Clearly an indication to stop the study after 35 patients. The landmark paper by Barrett and Jordan published in Lancet. Now, we've used heparin for virtually 50 years, and it was only until 1985 that the heparin was fractionated into its smaller components, and low molecular weight heparin became available, which permitted the subcutaneous injection with very good bioavailability. And since then, there have been numerous studies in terms of prophylaxis and in the treatment of venous thromboembolism with low molecular weight heparin in place of the unfractionated heparin. The advantage, of course, of low molecular weight heparin is that you can untether the patient from the IV bowl. You can give it at home. So this has been a tremendous development. Now, thrombolytic therapy is also an old form of therapy. It just hadn't taken off. Streptokinase was discovered in 1933. Urokinase was discovered in 1947. The advantage of urokinase was that it was a human product and therefore non-antigenic, whereas streptokinase came from the streptokinase or streptococcal bacteria, and so it was a foreign protein. But the problem with urokinase was it took hundreds of gallons of urine to isolate enough urokinase to treat a patient. And that persisted until 1967 when Bernick and Kwan at Northwestern were able to isolate urokinase from human kidney tissue culture cells. And that's how urokinase is produced all these years until it was discontinued several years ago. Now, following the successful completion of 3 pilot urokinase studies, the NIH sponsored the urokinase pulmonary embolism trial, and that was the first multi-center trial that the NIH has ever sponsored. And there were 8 centers, and there were 160 patients accessed to that study. There was significant clinical improvement in the urokinase group, as well as hemodynamic improvement. However, there was no mortality difference. And a year later, the urokinase streptokinase pulmonary embolism trial also showed that both urokinase and streptokinase were superior to heparin, but there was no mortality difference. And there also was a higher hemorrhagic complication. And so that was a major problem, and hence suppressed the widespread use of thrombolytic agents. Well, Dr. Goldhaber thought about this for a while. I don't know how long. But knowing that the duration of therapy was a very high risk factor for hemorrhagic complication, and urokinase and streptokinase had to be given for 12 to 24 hours, Sam decided, let's really shorten this. And there was a new thrombolytic agent called TPA, which was very potent, very rapid onset of action. And he said, I'm going to give it for 2 hours, and then we'll see what the results will be. As it turned out, it was highly successful. He carried out several clinical trials, and the FDA approved the 2-hour Goldhaber regimen, which is currently what we use now. I want to end with the history of the surgical procedure. I will leave the fascinating story of pulmonary embolectomy to Dr. Cohen, who will discuss that. But in the 20s, the thrombectomy, removal of the clot, was introduced by the Riche syndrome, or obstruction of the aorta. And then in the United States, John Homan at the Massachusetts General Hospital began to ligate the femoral veins and the inferior vena cava to prevent pulmonary emboli. However, it was a pretty heroic procedure with a number of complications. And thrombectomy was also carried out. But then they began to think that without permanently ligating the vein because of its consequences, why don't we temporarily, or why don't we put in a filter which can trap the clot but not impede the blood flow? And hence the origin of the inferior vena cava clips and devices. The first was in 1959, described by Moretz. It was a clip. It looks like a hairpin made out of plastic, which narrowed the inferior vena cava. Subsequently, the application of the inferior vena cava, the umbrella filter by Morin-Udine, and finally in 1973, the Greenfield filter, which came onto the scene. And subsequently, there have been at least 7 other filters, which in various configurations will trap the clot without impeding blood flow. And most of all, recently, within the past year, there's been an FDA approval of filters which are retrievable. Everything else is permanent, but now with a retrievable filter. However, the problem is that 80% of the time, the filters aren't retrieved. So, so we see here that the surgical aspects in terms of prevention require some kind of device within the inferior vena cava. I'd like to do after, as I said, Dr. Cohen will talk about pulmonary embolectomy and its fascinating history. But what I think the history of venous thromboembolism tells me is that there's been a great deal of activity in this field. There's been a lot of thought placed in terms of the diagnosis, in terms of the management. But in the past, very little attention has been paid to prevention. And I think that's the area that we're in now. And I look forward to the history of prevention in terms of venous thromboembolism. Thank you.